Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, an ECG management consultants company. We are a national healthcare consulting firm that is redefining healthcare together with our clients. In this program, we will explore the big trends in healthcare and have real conversations about how provider organizations can meet today's challenges, strengthen performance, and transform care delivery. Value-Based Care Insights is hosted by Daniel Marino, principal at ECG. For additional insights, visit ecgmc.com. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. Many hospitals struggle time and time again with managing a lot of the activities in the emergency department, and everything from overcrowding to long wait times to impact related to readmissions. Certainly on the value-based care side, many hospitals and health systems are thinking about different alternatives that help to provide additional urgent or emergent type support to patients. Certainly having patients go to urgent care, or at least being able to provide some other alternatives for emergent care and so forth. But it hasn't really done a lot to solve the problem with overcrowding. And, there's a whole host of reasons for that. I think some of it, potentially is the care model. I think some of it is the lack of primary care physicians, the shortage of primary care physicians. Some of it is just need. I mean, patients, have a condition, they have a clinical need, and they don't know where else to go, so they go to the emergency department. Well, I'm excited today to have my colleague, Marty Lucenti, join me in the conversation. Marty is a nationally recognized expert in emergency department operations. He's worked with organizations all over the country on emergency medicine delivery, optimization. He not only is an emergency medicine physician, but he has a PhD in mechanical engineering as well. Marty, welcome to the program.
Thanks for having me, Dan.
So, Marty, let's dive into this. When working with organizations around the country, what are you seeing as the big challenge, or maybe the big drivers related to overcrowding in emergency departments?
I think the starting point when you start to look at overcrowding in the emergency room, it's really important to start with, what do you see emerge as the patterns of utilization in the emergency room? What does the emergency room of today provide for the health system? And quite honestly, when you take a look at what the emergency room does now, I like to refer to it as the emergency room has slowly and predominantly transformed itself into an acute diagnostic center. And because much of the original physical footprints were originally designed with the primary concept of an emergency room. This is where you go when you have a life-threatening emergency. A lot of the capacity designs were done with that in mind. But when you actually look at, the populations that actually present to the emergency room forms a much broader set of services for the health system. When you look at the populations within an emergency room, there is that group that is, has a life-threatening injury or illness, but that only represents about 25 to 30% of the ER visits. There's another 25% that are relatively low acuity, but that low acuity often requires some uniqueness of scope of practice. The misperceptions often about low acuity emergency room visits is they could have gone to an urgent care, they could have gone to a primary care, when oftentimes even the low acuity visits in the emergency room were actually referred over by urgent cares or family practice or primary care providers just because of scope of practice.
Sure.
Don't do incision and drains, not comfortable, doing some light sedation on a child to do suture repairs and so forth. So that represents another 20-25% of the emergency room. But the area that has become the dominant center of massive patient care in the emergency room is actually this complex patient population, patients who have either medical complexity, have a lot of comorbidity issues, or have a complicated problem. They're not acutely decompensating. They're not in the process of dying,
Sure.
but they're getting sicker, and they've got and in order to really fully evaluate them, there's a lot of diagnostics and potentially a series of different scopes of practice, specialty perspectives that need to be interjected. And that actually represents almost 50% of emergency
Wow.
room visits. So it's an interesting constellation of presentations that come to the emergency room. Very few emergency rooms were fully designed with that full responsibility.
Sure.
The
Sure.
other part to look at, Dan, is the single greatest predictor of an overcrowded emergency room is a full hospital.
Right.
And
Well,
so
you see that all the time. I
the
mean, a lot of times,
yes.
when the census in the hospital is, above 90%, then all of a sudden the hospital's scrambling and maybe, they're discharging and getting
Yep.
transitioning the patient out, only to come to find out that maybe the post follow-up, post-discharge transitions care
Yep.
really those protocols aren't in place or the processes aren't in place as strong as they should be. So what happens? The patient shows up at the emergency department.
Yeah, and you used a number 90%, which shows me know a little bit about queuing theory, because you start to get balking when you get above 85, 90%. So there's
Yeah.
your number told me that you've got a little bit of a background, but you're exactly right, Dan. And so when you think about an emergency room, if you planned your resource model for everybody to come in, get 3 or 4 hours of care and leave, um, and then you have people waiting 2, 3 days for an inpatient bed, and you're more and more of your resources are transferred over to providing additional inpatient care because your inpatient services is over full. It really creates a strain.
Sure,
Once
it
again,
does.
I'll remind everybody, the single greatest predictor of an overcrowded emergency room is a full hospital, but
So,
it's that
Marty,
constellation. Yeah.
yeah, absolutely. So let me ask the question. In your experience, though, when you look at that, again, I'm going to use the kind of a physician analogy here. When you're looking at diagnosing the problem of overcrowding, right? Is it, what I'm hearing you say is it may not necessarily be that there's patients who are going there that shouldn't go there. Some of it could be as a result of just the poor processes that we have in place, the poor throughput that we have in place. Is that true? Is that what you're saying? And if so, how do we manage one or the other?
Yeah, here's what I would say is it's one. So Dan, you're dead on. Although you will see most people who try to fix this problem just believe that they can efficiency themselves into solving this acute
Yeah.
care capacity crisis. What I would tell you is the flaw generally starts before the process engineering. It actually starts with the resource planning and understanding stochastic or variable demand. We do so much planning based on averages, but these are queuing systems that have arrival patterns with distributions that have variability. And so, you've got to be able to use some of those statistical constructs from, high reliable system design to make sure that you've got enough resources to adequately meet the demand. When you
So let
think
me
about
dive
it,
into that a little bit because I want
yeah,
to put this into kind of a practical
yeah.
approach here. So are you saying that as you start to think historically about the patients who are presented to the emergency department, we should be looking at what the admitting ER diagnosis is and, begin to maybe risk stratify the patients so we can better almost create the care model based on historically profiles of patients who have come there? Is that what you're sort of referring to?
So what I'm saying is, take a look at your arrival patterns. So like when I fix an emergency room, whether it's an inpatient hospital or it's an emergency room, this is a traditional queuing system challenge. It's a capacity demand
Sure.
matching algorithm, right? So when I look at an emergency room, I have to have enough docs, nurses, and care spaces to take care of all the patients that arrive. So I study the demand by hour of day, day of week, week of month of year, and I understand distribution, not just the average, but the 75th or 90th percentile. If I want to be safe and reliable, I've got to be able to deal with my 90th percentile demand. Within that construct, Dan, you've got to understand the various types of presentations, the levels of acuity that come, and then exactly what you want to do is have designed care pathways for different levels. People want different types of patients want very, very different things, right?
Absolutely.
If you're a
Yeah.
high acuity patient, right? If you're a high acuity patient, there's only one thing you care about. Please save my life, right? You're not worried about comfort. You're not worried whether you've got a TV. You're not worried about communication. Just save my life. Likewise, if you've got a minor problem, really what you care about is getting discharged as quickly and move on with the rest of your life. So the care space design and so forth are very different for those subpopulations. And then that middle group, which I talked about, the 50th percentile, who have a lot of pre-existing medical issues that may or may not be deteriorating, that need a very big workup. Those people really do care about comfort because they're going to be there for a while. They were already uncomfortable with the chronic illnesses they're dealing with, and the challenges of trying to navigate the outpatient space that haven't given them the answers they're looking for. And so you're exactly right. And you need to know all of those things
Yeah.
with a probability distribution.
If you're just tuning in, I'm Daniel Marino, and you are listening to Value-Based Care Insights. I am here talking today with Dr. Marty Lucenti, and we're talking about addressing the overcrowding issue in the emergency department. So, Marty, I'm a big proponent of risk stratifying populations and risk stratifying
Yeah.
the patients. And I've felt like through the work that I've done with hospitals all over the country, the more that you know about the patient, the more you know about
Yeah.
the risk factors that are driving the needs of the patient, the more proactive you can be on delivering the exact care that they need.
Yeah.
When you think about, let's say, the high trauma patients or the
Yeah.
patients that are the rising risk patients or the patients, that are coming in, as you've kind of mentioned, those high acuity patients, how does the data figure into that? Because again, you're not necessarily planning for the emergency medicine visits. Patients just show up, right? So
Yeah.
how do you integrate that level of data, that level of informed knowledge into the care model so you're actually able to deliver that care and create the efficiencies that hopefully you're able to gain out of addressing the overcrowding issues?
Yeah, no, that's a really good question. And healthcare has spent a lot of money really trying to get to some of those solutions. If you look at it, centralization of electronic medical records so that the second I actually identify you, I am immediately fed all that information. Think about, a lot of trauma is generally a young person's game. Most of the people we see in trauma are young, but there's a decent population that are geriatric trauma.
Sure.
And
Yeah.
when I'm dealing with geriatric trauma is a traumatic shock is usually a hypovolemic. They're losing blood. But there are other kinds of shock, cardiogenic and so forth. And so there's some special considerations when you're dealing with trauma patients if they've got, pre-existing congestive heart failure, and some of the traditional approaches would not work. So, having a robust, EMR with shared access so that the second you scan somebody in, that information is being fed to you is incredibly valuable. And you've
Oh
seen
yeah.
health systems across the
Yeah.
country have spent a lot of money, actually they know in the in their soul that having all that information in one place, easily accessible, is going to lead to better outcomes. And I think it's on this front, right? In time critical moments, the quicker you can assimilate all that information and calculate it into your diagnostic and
Yeah.
therapeutic interventions, incredibly helpful.
It absolutely is. I mean, that's where the efficiency in the care comes in, and we make
Yeah.
sure we're providing the right level of care for the patient that needs it. Talk a little bit in terms of what you've seen around the country with some of these innovative models. In some cases, when I've had the opportunity to go in and to assess workflow in the emergency department, we've assessed kind of the overcrowding issue and kind of the throughput of it. You can't oftentimes, and again, I'm not a physician, but oftentimes I think that a lot of the workup and a lot of the activities that are being done isn't necessarily focused on patient need. It could be focused on a protocol. It could be liability factors that come into play too, making sure that we're doing all these tests to rule out certain, this, that, or the other that comes in. But I don't really see that as innovative models, right? I think it's more of just standard operating procedures. What do you see are some of these innovative models that are combining the knowledge, the data, the innovative, throughput and care models that are really helping to take these emergency departments to more of a high performing standard?
Yeah. So the first problem you always have to solve is that capacity demand problem, right? And if you have enough resources to just serve that first function, which is, keep people alive who have emergencies, you're going to be problematic on all the other patient populations that you have to provide care to. So solve that problem. But that's when, after that, Dan, it starts to get to be really interesting, which is how do you design your emergency room and what should your emergency room do? There are folks, and you have to decide whether you're going to be sort of operate as a traditional emergency room, which is basically make sure they're not having an emergency. If they're not having an emergency room, discharge them with lots of follow-up visits, and try to get plugged
Sure.
into the outpatient care. Or you can take the other approach, which is this is an outpatient facility, and I'm going to give you the answer now. I'm going to put together that
Yeah,
which would take
right.
3 weeks, for you to get, efficiencies. And when you look at value-based care, there's a lot of emphasis, on efficiencies and quality. What I find, when I talk with specialists is the errors that I see in medicine are errors of omission, or means are predominantly things that didn't get done or should have been done
Mhm.
quicker, right? And
Right.
so,
Yes.
so the answer is most people, if you try to do a complicated workup in the primary care or outpatient facility, it's 5 different places with 6 different appointments, and it's hard to get all of those
Mhm.
somewhat coordinated. Whereas in the emergency room, you can get all of those things very quickly. I if you lean into the concept of an acute diagnostic center and set as a priority that this is where you come for an answer, which is much different than the emergency room that says you're not having an emergency, go try to work this up in the outpatient. You can really create a lot of value to your patient population, reduce suffering, eliminate errors, improve
Right.
efficiencies, all of those things. And so when you start to think about those sort of innovations, it's a philosophical difference in the way you go about approaching a
Absolutely.
patient who presents to the emergency room.
If I could
Yeah.
build off of a point, I really like what you mentioned about the transition from an emergency department to an acute diagnostic center, because that sort of
Yeah.
changes then the mindset, that paradigm shift on how we're treating patients and what the emergency department really should be doing. But, as you're talking through this, putting my finance hat on, there's an economic impact here, right? And
Yeah.
in some cases, the emergency department is an
Yes.
economic
Yes, there
engine
is, Dan.
or a hospital. In other cases, maybe not so much, depending upon the payer mix, but nonetheless, it does have some financial implications. How does the finance piece of this fit into it?
Well, I think this is a really great question. We can kind of walk through this, and I'll talk to you to kind of give you that the answer can be a little bit different depending on the circumstance. So if you look at the operating margin of a hospital, right? An operating margin of a hospital is, generally 1, 2, 3%. It is an
Right.
incredibly low margin business, right? So you honed in one of those very first principles when you mentioned 90%. So I was running an operation that has an incredibly low margin. I want it to be completely full. I can't have any excess capacity so that I'm reliable, because it cuts my margin, gets tighter
Sure.
and tighter.
Yeah.
And so being full with a waiting room, right? Being full with a waiting room makes some financial sense to the hospital, doesn't it? Right?
Yeah,
Always your next
absolutely.
patient is right down in the emergency room.
Yeah.
Not only that, Dan, but when you actually, depending on the circumstance, right? Full with a waiting room. All right. So once you're full with a waiting room, start to think about this. You have three different sources of patients. You have patients that come from the ER, patients that get admitted to the hospital from the OR, and patients that are transferred in for specialty care. What do you make? What do hospitals make the most money on? Which patient populations?
Well, I would imagine patients that, are come from the emergency department and getting admitted into the hospital.
No, that's the lowest margin patient. That patient that is the poorest insured and the lowest problem mix of those. So you make the most money off your OR patients, the second most off your
Oh, yeah,
transfer
you're right.
patients,
Okay, you're
and
right.
the final is the ER patients. So start to think about it as if once I get full, I back up into the ER, it does actually, in some sense, create a little bit of a negative feedback to your lowest
Mhm.
margin point of entry to your facility, doesn't it?
Yeah, you're absolutely right. Right, because that's where the contribution margin is going to come in. So maybe it's then designing, as you
Yep.
mentioned, the ED is an acute diagnostic center that helps to manage some of those trauma patients and almost thinking about maybe the medical side of emergency
Yep.
department different than the procedural side of the emergency department. So then you are able to kind of address those trauma cases quickly and efficiently.
Yeah, what I generally do on that. So once you get to that, like what you start to do is what I usually will do in those circumstances. So right, this is a full hospital. This is most
Sure.
downtown academic medical centers. They're full with the ER backed up with boarders. What I generally do is try to hybridize that, which is basically I make the ER both an ER and an OBS unit, and they're not physical locations, but their
Yeah.
status is within the same physical space. So that I try to reduce the admissions. I try to reduce the admissions by 25% by keeping the patients and being really efficient at getting them the CAT scans, MRIs, the
Hmm.
consults, and avoid a 2 or 3 day admission by being ultra effective, ultra quick at getting diagnostics and consults in an ob status so that I can filter off 25% of the admissions. They're thus decreasing my tomorrow's challenges. Take the opposite approach though, Dan. You're a hospital that's it's 30 to 40% occupied, that's having financial trouble.
Hmm.
You'll see them use their ER as a mechanisms to grow desirable. So a lot of times when I work with for-profit organizations, they look at the ER completely the opposite. They don't start a negative feedback to their ER because they're already full and they're trying to enrich their problem mix. They look at it the other way. This is my point of entry for a lot of relatively lucrative stuff to grow my inpatient volume and so forth. So once again, it's not the ER isn't one piece. There isn't one answer to how you configure an emergency room. You actually have to configure that emergency room to be most effective in the broader care system that you're providing your
Right.
community.
Yeah, well, that's a great point, and really based on, historically what the needs are of the community, needs are of the patients, and so forth. Well, Marty, this has been great, and I think we just barely scratched the surface on this. As many organizations, they're continuing to work through efficiencies in the emergency department, address overcrowding, all of those issues. If any of our listeners are interested in contacting you, can you share your contact information or your LinkedIn address?
Sure, sure. It's MJ Lucenti at ecg.com is my email.
Wonderful. Well, I appreciate it, Marty. This is great. And, I'd love to maybe down the road talk about some specific case studies. This is such an important topic and it touches so many
Good.
different areas.
Yeah,
Maybe sometime down the road I'll have you back in, but I'd love to kind of dive into some specific case studies with some outcomes. I think that would be really interesting to
absolutely.
talk through.
Yeah. Love to dive in deeper. Yeah.
Wonderful. Well, thank you for coming on. I really appreciate it. And a special thank you to all of our listeners for tuning in. If you're interested in learning about this topic or any of the topics that we've discussed on Value-Based Care Insights, please log into Lumina hp.com/insights or visit ecgmc.com for a lot of other information and quite a few of the topics that we've discussed. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Thank you for being with us today. If you're navigating the shift to value-based care or looking to enhance the performance of your organization, we're here to help you move forward with insight and impact. Visit ecgmc.com to connect with Dan Marino and explore our advisory services. While you're there, check out our latest insights and thought leadership, follow us on LinkedIn, and join the conversation using hashtag VBC Insights. We're Lumina Health Partners, an ECG company. Until our next VBC Insight, keep leading the change.